let me introduce Dr. Kapoor. Dr. Prashant Kapoor is an associate professor of medicine and chair of the Waldenstrom's macroglobulinemia working group at Mayo Clinic in Rochester, Minnesota. Upon completion of his hematology and oncology fellowship training in 2012 at the Mayo Clinic in Rochester, he was invited to join the Division of Hematology as faculty. He is a recipient of several awards, including the Kurtz Myeloma Research Fellowship, the American Society of Clinical Oncology Merit Award, the Department of Medicine Career Development Award, the Research Innovation Award, Transplant Center Scholar Award, and the Department of Medicine Faculty Scholar Award. His research is focused on evaluating novel agents in plasma cell disorders, and he is the principal investigator of several investigator-initiated and industry-sponsored clinical trials. He has served on the Mayo Clinic Institutional Review Board and is currently a member of the Mayo Clinic Data Safety Monitoring Committee. He's a passionate educator and has presented his work at national and international doctor and patient forums. He has served on the editorial board of the American Society of Hematology, Daily News, and co-site editor for another myeloma publication. At present, he is the myeloma section editor of Current Hematology Malignancy Reports, and he has over 350 peer-reviewed publications in prestigious journals such as The Lancet, the Journal of the American Medical Association Oncology, Journal of Clinical Oncology, The Lancet Oncology Blood, and The Lancet Hematology. He is a fellow at the American College of Physicians, an active member of the International Myeloma Working Group, and the American Society of Hematology, and the American Society of Clinical Oncology, as well as the International Myeloma Society. So we have a very accomplished speaker, as you can see, and I now turn the program over to Dr. Kapoor.
Thank you, Joel. It is indeed my pleasure to be speaking on such a momentous occasion, birthday of Dr. Waldenstrom, as well as Waldenstrom Macroglobulinemia Awareness Day. And I am really glad to have so many people join online. I will start off with a brief history of this condition that was actually named after Dr. Jan Waldenstrom. And this was back in 1944 when he described, so over 80 years ago, when he described a couple of cases that seemed to be presenting like what is known now as Waldenstrom macroglobulinemia, when patients presented with nosebleeds and mucosal bleeds, as well as high IgM levels, increased serum viscosity. And I will go into those details during the course of my talk. But interestingly, these patients, when they underwent bone marrow biopsy, had a very distinct appearance of the blood cells. So bone marrow is the area where the blood cells are formed, and that's where they reside initially. And the blood stream is in a continuous phase attached to the bone marrow. And these are two, while they are designated as two separate compartments, so to speak, there is a constant interaction. The blood is formed within the marrow and then flows peripherally. So here you can actually see two distinct types of cells. One is the small lymphocytes, and at the other end of the spectrum is the plasma cells. These are all B cells, a type of white blood cells, specifically a type of lymphocytes. But in between, you will see some cells that neither resemble this completely, the plasma cell, nor the small lymphocytes, but are actually somewhat of an integration of the two extreme cells that you can see. So they are called plasmacytoid lymphocyte or lymphoplasmacytic cells. And in the marrow of a patient with Waldenstrom, you would find a group of such cells called clonal lymphoplasmacytic cells. And that is what the pathologist looks out for at the time of the diagnosis. And that is why performing a bone marrow biopsy is an essential and integral component of the diagnostics for WM. So what I was trying to say is there's a spectrum of cells within the bone marrow, and at one end of the spectrum you can see small lymphocytes. At the other end, more mature plasma cells, and in between you can see lymphoplasmacytic cells or plasmacytoid lymphocytes. And this is what a pathologist sees under the microscope. And what you are right now seeing is a sample of bone marrow aspirate. So Waldenstrom macroglobulinemia is actually a distinct clinical-pathologic entity. We talked about the pathologic features of this condition, but there is a clinical component as well. And one important component is the presence of circulating protein called IgM or immunoglobulin M. And it is a very distinct protein in the sense that it is monoclonal. We all have IgM, and these are antibodies that help us fight infections. But in patients with Waldenstrom macroglobulinemia, there is a specific type of IgM which is monoclonal, and it's been categorized as monoclonal because it is produced by a distinct group of cells, and those are the Waldenstrom cells or WM cells, lymphoplasmacytic cells. When this circulates in the blood and is monoclonal, in the setting of this lymphoplasmacytic infiltrate, plus end organ damage as a result of increased lymphoplasmacytic infiltrate, as well as IgM monoclonal protein, one can call that entity overt Waldenstrom macroglobulinemia or active Waldenstrom macroglobulinemia, also known as symptomatic Waldenstrom macroglobulinemia. And speaking of symptoms, there are a variety of symptoms one can actually encounter. Many of these symptoms are very nonspecific, starting from fatigue, which is a very common symptom. Additionally, what we as hematologists call B symptoms, such as weight loss, drenching night sweats, low-grade fevers, and these are persistent, not just once in a while. These are persistent. And other non-specific symptoms such as joint pain, also called arthralgia, Raynaud's phenomenon, where the tips of fingers, nose, ear, they can turn, or toes, they can turn blue, especially in cold. And patients like to wear socks and ensure that the circulation is preserved. Patients can present very commonly with something called cytopenias. Cyto means cells and penia means low grade. So cytopenia is in the form of anemia or low hemoglobin or red blood cells, can also be in the form of low platelets called thrombocytopenia. As a result of anemia, patients can experience profound fatigue, shortness of breath on exertion, sometimes lightheadedness. As a result of thrombocytopenia, patients can experience bleeding because platelets help prevent bleeding. And when the platelet count goes low, bleeding can be a complication, especially if they are very low. Additionally, about 15% of patients can present with adenopathy or enlarged lymph glands. And this lymphadenopathy can occur anywhere in the body. Some of these lymph nodes are what we call palpable or can be easily felt upon examination, and others are deep down in the abdominal cavity or the belly area, and can only be recognized or detected on the basis of radiographic tests such as CT scan or PET-CT scans. And this, in conjunction with enlarged spleen, an organ on the left-hand side, upper quadrant, left upper quadrant, behind the stomach, can be seen in about 15% of patients. Hyperviscosity syndrome, or HVS, is a dreaded complication of Waldenstrom macroglobulinemia, where patients can present with epistaxis or bilateral nosebleeds, in other words, through both nostrils, headache, impaired vision. And these are uh, features that are actually encountered, and they manifest as a result of very high level of circulating IgM protein. Now, IgM structure is such that it is a very large molecule, and it can lead to what we call sluggishness in flow of the blood, or increased viscosity. So the blood doesn't flow through the vessels easily, and as a result doesn't reach the brain as easily, and sometimes can manifest as headache or rupturing of small capillaries in the nose area, as well as mucosa within the mouth, where because of this sluggish flow or impaired flow of blood, there can be what we call stasis and increased pressure on the blood vessel wall. And if the wall is of a thin vessel, such as capillary, it can rupture, and as a result, patients can experience bleeding. When such bleeding occurs within what we call retina, or the film on which pictures are formed, when we see, and that leads to brain recognizing everything that we see. When this occurs within the retina, it can manifest in the form of dot plot hemorrhages or tortuous blood vessels, where they can become engorged as a result of sluggish blood flow and become more prominent. And this is something that can be detected through what we call a fundoscopy. And fundoscopy is examination of the back of the eye or the retina um, on a dilated eye, where the pupils are enlarged, and they are enlarged deliberately by putting in some eye drops that lead to pupillary dilatation, so that even the periphery of the retina can be reviewed carefully by an experienced eye doctor. And that is important as well, because sometimes that impaired vision may be a late feature, and much after the central area is affected, and in order to detect it in a timely manner, especially in patients who have elevated viscosity and have a high likelihood of developing such features, it is best to just get it done periodically, so as to find out if there are early telltale signs that could prompt initiation of therapy. Now, IgM is, as I said, a large protein, but it can do a lot of funky things. It can get deposited um, in the nerves as anti-myelin, anti-nerve sheath antibodies, and can lead to what we call peripheral neuropathy. There is a condition called AL or ALH amyloidosis, which is essentially misfolding of the monoclonal protein that is secreted by these Waldenstrom cells, and deposition of this protein in different organs such as heart, kidney, lung, liver, etc., including the GI tract, gastrointestinal tract. And sometimes patients can present in the form of cold agglutinin disease, where there is actually clumping of cells as a result of stickiness of this protein that leads to eventually rupturing of these cells. And cryoglobulinemia is another condition which occurs as a result of precipitation of this protein, circulating IgM protein, in cold temperatures, as a result of which blood flow to organs is compromised and can manifest in the form of organ dysfunction. One thing I want to elaborate a little bit on is the genetics and the different pathways within a Waldenstrom cell. So I showed you previously those lymphocytes, but why is it that these lymphocytes and lymphoplasmacytic cells, the B cells, why is it that they are growing on their own? Is it something that we are feeding and them? And the answer is no. They sort of become these autonomous self-surviving cells. And that is a result of activation of a number of cell growth or cell proliferation pathways. And the pathways do become activated as a result of certain genetic alterations that occur within the Waldenstrom cells. Mind you, these are not in the so-called germline cells, cells that we pass on to our kids, but they are present in Waldenstrom cells that develop over time. And these mutations, such as the MYD88 mutation, which is seen in upwards of 90% of patients, as well as CXCR4 mutations, which is seen in about 40%, up to 40% of patients with Waldenstrom macroglobulinemia, can lead to activation of certain pathways that in turn can lead to cell growth and survival. And that leads to increased activity of these cells and increased secretion of IgM, which serves, fortunately, as a surrogate marker. So think of IgM as a product um, uh, of the factory, which is Waldenstrom cells. So the factory is producing this product, and then if the product goes up, that means the factory workers are churning out the product very rapidly, although there isn't always a one-to-one correlation with the IgM levels. In other words, there can be low involvement or low degree of involvement by Waldenstrom cells, but still a high level of IgM product. That means even though there are fewer workers, most of them are secreting a lot of this IgM protein. Where this IgM protein becomes very helpful in managing patients with Waldenstrom macroglobulinemia is when we first diagnose, because the presence is important. That is one of the components of the diagnostic features. But also, if the IgM levels go down as we treat patients, that means the patients are responding or are in remission. So if there is a 50% decline in the IgM protein from the baseline before starting treatment, that means patients are in partial remission. If there's a 90% decline from baseline, that means they are in very good partial remission, because if the product goes down, we know that the factory is shutting off. While we can do bone marrow biopsies repeatedly, it's not ideal to do because we recognize it's an invasive procedure and a painful procedure, and we only want to do it if needed to change our management or for response assessment if we are unable to figure out from IgM whether a patient level, whether a patient is actually responding or not. But by and large, in the vast majority of patients, IgM is a very helpful surrogate marker for what we call the tumor burden. And within a specific patient, if the baseline levels are improving, that is a very good sign for us that the treatment is working. But it is not just the Waldenstrom cells that are assisting with IgM production. In fact, the cells surrounding this Waldenstrom cells, what we call the tumor microenvironment, is equally important and sometimes is co-opted by the Waldenstrom cells that harness the good cells and uh, uh, and use them to actually grow on their own. And so the tumor microenvironment becomes somewhat supportive to the Waldenstrom cells and nurturing to the Waldenstrom cells. And there is a constant crosstalk between the Waldenstrom cells and the surrounding tumor microenvironment, which can facilitate the growth of Waldenstrom cells. So this is actually just a cartoon of CXCR4 molecule, which in turn helps in attaching or latching on to CXCL12, one of the soluble markers. And as a result of this interaction of CXCL12 to CXCR4, patients can have Waldenstrom cells that are rapidly growing and can potentially be resistant to many treatments. But I will go with this background. I would like to go back to where we were originally with our topic of today, which is a very important topic of wait and watch. And one a very important advice of Dr. Waldenstrom, who is on this in this picture on the left-hand side, the taller gentleman, and on the right is Dr. Kyle. And the advice of Dr. Waldenstrom, was to let well alone. And that is something that has been repeatedly reinforced during my interaction with Dr. Kyle, who fortunately is still with us. He's at Mayo Clinic. He started the Waldenstrom program at Mayo Clinic about 60 years ago and was a friend of Dr. Waldenstrom. And Dr. Kyle has repeatedly reinforced this, that in an incurable malignancy such as Waldenstrom macroglobulinemia, it is important to ensure that we pull the trigger in terms of starting the treatment only when it is absolutely necessary. And during the course of this talk, I'm going to highlight certain features that would suggest to us that actually this is a very valuable advice. And one of the reasons for it is that there is no value to early intervention in terms of overall outcome. And this is an important entity called smoldering. There is an important entity called smoldering Waldenstrom macroglobulinemia, where you have these Waldenstrom cells, you have the circulating IgM protein, but what you don't have is the symptoms or the cytopenias or so-called end organ damage. And at the time of diagnosis, as Joel put it in giving his own history, sometimes this is just incidentally diagnosed during a routine blood workup. And what is then found eventually is this condition as a result of a bone marrow biopsy. But just because we've diagnosed this condition or find this condition in otherwise healthy individual who is not experiencing any major symptoms, we do not start treatment because as of 2025, we still don't have any study to suggest that early intervention would change the overall outcome. In other words, survival of patients. What is more important is in smoldering Waldenstrom, and we see up to 20 to 30% of patients at the time of diagnosis are in this smoldering stage. And in smoldering Waldenstrom macroglobulinemia, there is no value to early intervention. And this sometimes this condition is considered as somewhat akin to a sister malignancy called multiple myeloma, but smoldering Waldenstrom is not the same as smoldering multiple myeloma, as patients with high risk smoldering multiple myeloma are known to somewhat benefit from treatment, but that is not something that has been shown in patients with smoldering Waldenstrom macroglobulinemia. And this is a song, the lyrics of a song that you guys are very familiar with, The Gambler by Kenny Rogers, where we as physicians need to know when we need to hold our cards, when we need to stay away from starting treatment, and when it is important to continue waiting and watching, as was done in Joel's case, because what we do know is that with the initiation of treatment, we can actually turn an asymptomatic individual into a symptomatic individual because this treatment has its own side effects. So somebody who's otherwise not having any symptoms may become symptomatic as a result of the treatment, the side effects of the treatment that we would initiate. So our whole purpose of actually improving the quality of life would get defeated. But the risk benefit ratio of the treatment changes once we start having all these symptoms, in which case the patient is labeled as a case of symptomatic or overt/active Waldenstrom macroglobulinemia. I'm just trying to move this slide here. A long time ago, a very astute clinician, Dr. Madhav Dodapkar, who is actually a Mayo Clinic alum, um, had shown in a very important study in patients with Waldenstrom macroglobulinemia that you can indeed observe patients with Waldenstrom macroglobulinemia who are asymptomatic at diagnosis for a very, very long time. And that was done through this randomized trial of a drug called fludarabine, which we no longer use in the upfront setting and very rarely use in the relapse refractory setting. But the study was important for a variety of reasons, one of which was that the patients who were registered and followed prospectively for a long time, if they didn't have any symptoms at the diagnosis or at the time of the diagnosis or registration, and then over time, actually, time to therapy on this trial for patients was who were asymptomatic was very long, and you can see here at 9 years, only 21% of patients in this study actually required treatment. The 21% of those 59 asymptomatic patients. Again, showing the value of just observing them, but observing them closely based on their risk profile, which I will get into. Um, so what I'm trying to say here is that Waldenstrom macroglobulinemia has a precursor condition called smoldering Waldenstrom macroglobulinemia slash asymptomatic Waldenstrom macroglobulinemia, although the term asymptomatic is not considered as descriptive and as accurate as one would like it to be. And there is another condition called monoclonal gammopathy of undetermined significance, a term coined by Dr. Kyle. And this condition is actually a very common condition. An IgM type of MGUS or monoclonal gammopathy of undetermined significance is also fairly common in the general population. So just the presence of this abnormal protein in the blood is not necessarily equivalent of Waldenstrom macroglobulinemia. At Mayo Clinic, we say that patients have smoldering Waldenstrom macroglobulinemia if there is presence of at least 10% lymphoplasmacytic infiltrate in the marrow. If it is less than 10%, we label those patients as IgM MGUS. And patients with IgM MGUS have about a 2%, 1.5 to 2% chance of progressing per year to active Waldenstrom macroglobulinemia. Now, if the cell number is or infiltrate proportion is more than 10%, and they are called smoldering Waldenstrom macroglobulinemia, their risk of progression is much higher than the MGUS state. But what has been shown in a Mayo Clinic study is that during the first 5 years, their risk of progression to active disease is, first of all, highest, and it's about 12% per year. And so by the end of 5 years, about 59, 60% of patients would progress. Although this was not witnessed in the previous study I showed you, where over a course of 9 years, only 21% of patients presented or eventually progressed to avert Waldenstrom macroglobulinemia. So, be that as it may, the rate of progression is higher in patients with smoldering Waldenstrom macroglobulinemia compared to their IgM MGUS counterpart. But what is important to also understand is that after the first 5 years, the rate of progression per year decreases substantially for the next 5 years, where only about 8 to 9% of patients progress over the next 5 years. And beyond that, the rate of progression is actually very similar to the rate of progression in IgM MGUS. So the longer you are free of symptoms, and don't have significant what we call cytopenias, anemia, thrombocytopenia, the better the outcome is, or the likelihood of it not progressing to full-blown active diseases. But what happens during this progression from precursor conditions, IgM MGUS and smoldering Waldenstrom, is that patients develop new genetic abnormalities, new changes in their chromosomes, new features are acquired over time, and those lead to a survival advantage of these cells that go on from less than 10% or about 10% to 30, 40, 50, 60, and even 90, 95% involvement of the entire marrow, thereby compromising the marrow's normal function, which is to produce blood. And so patients would present with anemia and the clinical consequences of anemia, as well as thrombocytopenia and its clinical consequences. But it's also important to distinguish between IgM MGUS and smoldering Waldenstrom, as these are distinct entities. As I just spoke, the likelihood of MGUS going on to develop Waldenstrom is much lower than the likelihood of smoldering Waldenstrom to develop active Waldenstrom. But not every patient goes straight from MGUS to smoldering to full-blown active Waldenstrom. There can be transition from MGUS to full-blown or overt Waldenstrom, and we might miss out on that artificial construct, that period of smoldering Waldenstrom macroglobulinemia during our observation period. But there are a variety of factors that dictate the rate of progression, and it's not dependent on one factor, but the outcome of patients in general at the MGUS stage is better than the outcome of patients at smoldering Waldenstrom stage. Although there are studies, including a study from our institution, that shows that actually patients with smoldering Waldenstrom macroglobulinemia, excuse me, I'm just trying to see if I can move this slide. Patients of smoldering Waldenstrom macroglobulinemia are surviving as long as their age and sex and calendar year matched general population, which is a very important, actually, statement that I am making here based on a study out of Mayo Clinic, as well as a study that was done a long time ago by the Spanish group. What these studies have shown is that what we call SMR, or standardized mortality ratio, of patients with asymptomatic Waldenstrom or smoldering Waldenstrom is very close to that of the general population and close to one. When we did that same study, our SMR was 1.1, which is they are doing just as good and surviving as long as their matched counterparts from the general population. Another reason why it's important to just wait and watch is because we have actually had patients at Mayo where we have watched them regardless of their IgM levels. And some of these patients actually have had levels upwards of 6 grams or 6,000 milligrams per deciliter and are still managed expectantly because they don't have clear indications of treatment that I outlined in my first slide. They don't have anemia, they don't have thrombocytopenia, they don't have B symptoms, they don't have severe fatigue, they don't have severe peripheral neuropathy, or any reason for us to pull the trigger on the treatment. And in fact, when we exclusively studied the patients who had high IgM levels and just who were observed, we found that it was only after 7 years that half of them actually required treatment, and the other half were all still continued to be managed just on observation alone or expectantly, as we say it. So IgM levels are important, but they do not determine whether we need to start treatment. In fact, just yesterday, I had a patient who's had smoldering Waldenstrom macroglobulinemia since 2014 and is still being observed in 11 years out, and most recent levels are upwards of 6,000. What I'm trying to suggest here is we want to make sure there are no specific indications for treatment, but we also have to be very careful as to when we want to pull the trigger. Because one of the consequences of high IgM levels is increased viscosity. So it's important for us to look at the back of the eye, ask the ophthalmologist or eye doctor to give us a good report, make sure there are no clinical consequences of high IgM levels. And even if the viscosity by itself is elevated, that's not an indication for starting treatment in an asymptomatic patient. And over the course of the disease, what we have found is that only 15% of patients with Waldenstrom macroglobulinemia develop hyperviscosity related features such as severe headache, just cloudiness, or uh, bleeding as a result of high IgM levels. But there is no randomized data, in other words, no data where some patients are on one arm of the study, the intervention arm, and some patients are on the observation arm or control arm, um, to show that patients who are treated early on with early intervention would have a better outcome than those who are just observed. And some clinicians have also stated, and including patients, that majority of the patients with Waldenstrom macroglobulinemia do not suddenly just become symptomatic um, just before they require treatment. It's over a course of time, because what we need to understand is that this is an indolent disease, and the treatments become severe only over time, and generally over weeks to months. And we need to be vigilant about these so-called red flag symptoms, but we need to observe closely, and when in doubt, um, get checked, seek prompt medical attention to see whether treatment is required and something can be done. There have been different models to predict who would actually progress fast and who would not. And there are features um, within the Waldenstrom cells, such as lack of the presence of MYD88 mutation, that could lead to shorter time to progression from smoldering to active Waldenstrom stage. And so there are calculators that have been built in where we would be able to just plug in numbers like the albumin, the beta 2 microglobulin, etc., to figure out what the probable rate of progression would be, and accordingly devise a plan unique to that patient in terms of active surveillance, how closely to monitor, etc. So, what I'm just trying to say here is wait and watch is the way to go because we don't change the survival by early intervention. We know that only 12% per year progress. So, in other words, if you look at it with this glass empty, glass full analogy, about 88% of patients will with smoldering Waldenstrom will not progress in that year. The thing is, for first 5 years, the rate of progression is somewhat similar, so 12% per year, and our strategy should be to continue watching closely, especially in the first 5 years, and then we can reduce the frequency of bringing patients in. And by watching, I mean you do the routine labs, you do active surveillance with asking or inquiring specifically about certain symptoms. And what we have seen is, as I said before, that it takes, even in patients who have very high levels of IgM, upwards of 6,000, it takes about 7 years on average for these patients to progress. So there is no reason to pull the trigger on treatment, but there are other features as well. And what you can see here, let me just well, there are different types of models, as I talked about. And again, this is just a recapitulation of what I have said so far. But IgM levels, level of bone marrow infiltration, level of a protein called beta 2 microglobulin, which is secreted by the Waldenstrom cells, as well as low levels of albumin, can determine what the rate of progression would be. And there is a calculator which Dana-Farber, in conjunction with Mayo Clinic and a group from Greece, has developed called which is easily accessible, www.awmrisk.com. And in fact, you can plug in the numbers and essentially look at what your chances of progressing are over time. What I want to also say here is that very recently at the IWWM workshop in Prague, it was a consensus was reached as to how to define high-risk smoldering Waldenstrom macroglobulinemia, a group of patients that have about less than 2 years to progress. Within the first 2 years, half of those patients would progress, and that is on the basis of the risk score as calculated on that calculator, or because of the presence of MYD88 genotype, specifically a characteristic that your doctor can talk to you about and determine on your bone marrow cells, as well as the presence of another abnormality called TP53 mutation or deletion 17p or short arm of chromosome number 17. Now, these are more medical they come within the realm of, I think, medical jargon at the moment, and I don't want to elaborate too much on it, but it is important for you to reach out to your clinician and ask them to risk stratify your Waldenstrom macroglobulinemia. This is a manuscript that we are publishing and should be out shortly within the coming weeks. And with that, I would actually just like to come to one. Sorry, this is not moving properly, but I just want to, in the interest of time, just reiterate what I have been saying throughout this talk, that about a substantial proportion of patients with smoldering Waldenstrom will not progress off therapy for a long time, and it's best to wait and watch. And I know it can be worrisome, but that is a strategy that has been followed for years and has served us well. We also know that after the first 5 years of diagnosis, the risk of progression to active Waldenstrom macroglobulinemia reduces substantially. And the survival of patients with smoldering Waldenstrom is no different than their aged and gender matched general population. There are no studies to show that early intervention prolongs treatment. In fact, if we give somebody treatment, we are not only going to reduce their quality of life, but also we are likely to make their Waldenstrom cells resistant to that treatment over time. So there are actually harms or disadvantages to starting treatment early on. And in fact, study from Mayo Clinic has also shown that we can safely continue to monitor patients who have even very high circulating IgM levels. Had this disease been curable, we could have considered treatment early on, but as of right now, in 2025, it remains an incurable but very much treatable condition. And the treatment related toxicities are something that we have to be very mindful of as clinicians because they are not trivial. There can be long term impact of certain therapies which are outside of the scope of discussion of the today. But we can actually build a plan or tailor surveillance based on the patient risk profile that can be captured fairly adequately based on the tools that I discussed about. Lastly, we need to join hands that since all of you know this is a rare condition and international studies that prospectively follow patients over a long period of time can actually deliver great results and help us change our management. And with that, I would end my talk and give the next 10 minutes for any kind of questions that people may have. Thank you.
Thank you, Dr. Kapoor. We do have some questions already lined up for you. Question that was actually sent in before your presentation, which you covered beautifully. We have someone that was diagnosed with Mugus 18 years ago and was asking, what are the chances are they're going to ever transition to Waldenstrom's?
Okay, great question, and thank you for asking that. Well, what I should have stated, and I apologize that I was not very clear in my initial talk, that the risk for patients who have IgM-MGUS stays constant over time. And if it is 1.5% per year risk of progression, it remains constant. And just because someone didn't progress within the first 18 years doesn't mean that they wouldn't progress within the next few years. But at the same time, it is very reassuring that somebody's MGUS has a stable clone. What I'm trying to emphasize here is that patients require lifelong surveillance. We can't say that the risk becomes zero after a certain period, but unlike smoldering Waldenstrom macroglobulinemia patients where the risk ratio changes and actually over time, after 10 years, it becomes very similar to the rate of progression with IgM-MGUS. So smoldering Waldenstrom macroglobulinemia patients may behave like IgM MGUS patients, but IgM MGUS patients who, by the way, have normal lifespan, which is very similar again to the general population. And in fact, some studies have shown even better because they follow up very closely with physicians. And so their clinical assessment and primary prophylactic approaches might lead to even better health outcome than their general counterparts, which may not even seek medical attention. But that is again something outside the scope of this talk. But what I'd want to emphasize is uh, the risk is lifelong, but it is very reassuring that somebody for 18 years has not progressed, that even though the risk doesn't change, risk of progression, it tells us that the clone is rather stable and likely not acquiring new features over time, new cytogenetic changes. Hope that answers the question.
A follow-up to that, can the characteristic of fatigue be associated with MGUS?
Sure. So MGUS in general is considered an asymptomatic condition. Now, it can sometimes be seen or maybe a little more prevalent with certain other conditions because the patient goes to or someone goes to the doctor and gets, let's say, diagnosed with certain other conditions. And during the process of that workup, they find out that there's this abnormal circulating protein, which, by the way, had nothing to do with the original condition the patient went with. But now you see what we call clinical MGUS, which means they went in with certain symptoms and they came out with a new diagnosis of a condition, a mouthful that they had never ever heard of, monoclonal gammopathy of undetermined significance. But frankly, the condition by itself should not cause any symptoms. IgM, MGUS, or for that matter, IgA, IgG, MGUS should not cause symptoms. Symptoms may be related to some other disease, which may not have any bearing on the MGUS per se.
Thank you. So we have another question regarding smoldering Waldenstroms. So what blood tests are important and how often should these blood tests be performed?
Okay, so a great question, but I'm just going to tell in general terms because, like I said, the best way to develop an individualized approach is through that risk calculator. What I generally do in my practice is that for first 5 years, we see patients every 3 to 4 months. And the tests that we specifically do are monoclonal protein studies to see where the IgM levels are. We also look at hemoglobin. We look at platelet count. We look at white cell count, so CBC. We look at some of these comprehensive metabolic panels, such as that would involve the kidney function, the liver function, etc. At the time of the diagnosis, we also do 24-hour urine protein electrophoresis, where we check if there is any evidence of leaky kidneys. In other words, if there is a lot of albumin, a protein that can be seen, especially in patients who have coexisting amyloidosis, and there are about 7 to 10, 8% of patients with Waldenstrom who can have coexisting amyloidosis. So there are certain blood tests as well as this 24-hour urine protein electrophoresis. And if that was fine to begin with, then I don't necessarily repeat every 3-4 months the urine part, but the blood work we continue to do. Now, if I see that somebody's IgM levels are going rather up very rapidly, or hemoglobin is down, but it is not low enough to start treatment, and our threshold for starting treatment is 10 grams per DL and a platelet count of 100,000. So if I see that it's going towards or moving towards that direction, then I would probably follow up more closely. So it's a clinical decision at that point, depending on where those features land. Now, if a patient tells me that they have some red flag symptoms such as severe fatigue, which is constant, not like day-to-day fatigue, which I believe bet every one of us experiences, but severe fatigue or new symptoms, worsening neuropathy and all, then I'll follow that patient very closely. Or I would do additional tests such as a bone marrow biopsy to see has there been actually an increase in the overall disease stage or tumor burden before I pull the trigger on treating the patient.
Okay. So one of our questions was if a person is experiencing anemia as a symptom, would treatment be imminent? But it sounds like it would be a quality of life.
Right. And there
Okay.
are certain prognostic staging systems that do use hemoglobin as one of the features to uh, uh, predict the rate of progression. So if somebody has anemia to begin with, their likelihood of getting treated is somewhat higher, I would say. Again, it all depends on the degree of anemia, and different studies have different levels of hemoglobin that they have shown to be predictive of progression. But overall, I would say, unless the patient is very symptomatic from that or the level is less than 10, we don't start the treatment.
Well, I think we have lots of questions, Dr. Kapoor, but running out of time. So I will ask one more question here. Someone wanted to know if an optometrist can follow WM patient when they're in watch and wait, or would you
Yes,
recommend an
optometrist would be just fine.
Okay.
They have the skill to detect. They have the experience. But it's advisable, frankly, to let the optometrist or for that matter, the ophthalmologist know that what the specific reason for your eye exam is. So they are vigilant and they are not just sort of evaluating you as just a general run of the mill kind of person who's walked into their clinic for routine testing, so to speak.
Okay. Well, thank you very much, Dr. Kapoor, for taking time to meet with us today on Waldenstrom's World Awareness Day, and mostly for sharing all your wisdom with us. We truly appreciate this and everything you do for our community. Thank you so much.
Sure. I just want to say thank you for taking the time to listen to this talk. But if you want to reach out to me, I'm available by email. And if you want a formal appointment at Mayo Clinic, feel free to call up, and the numbers are all at Mayo Clinic website, as well as IWMF. And you can also look for a center closer to your place that may have physicians who are more experienced in treating your rarer condition, so to speak.
Let me just add that
Thank you.
it's often referred to as watch and worry, and I think after your presentation, we are all worried a bit less about
Thank you.
our condition. Sharon, you want to wrap up now?
Yeah, I want to also thank everyone who attended today. It will be recorded, so you can go back and listen to the recording. And then just a reminder that in May, the European Education Forum, which will be in Chantilly-Lace, but we can also join it virtually. So that's May 21st. And then our US Forum is on May 30th to June 1st in Ponte Verde Beach, Florida. Again, you can join virtually, but I really hope that you come and join us live. And if you have any questions about that, you can also find out from the office at iwmf.com or call for information. So I think that's it. A special shout out to Shelley for getting this organized. Dr. Kapoor, thank you again.
Thank you all.